How's it going, guys? We have a pass level question for pulmonary phys path step one. Okay, I have this stuff in the high yield arrows PDF, which I'll link in the comments down below. 15-year-old boy, he's had difficulty wheezing, breathing for 10 minutes on the soccer field. So history of eczema. So this is A to P with asthma, right? So A to P is going to be eczema in the summer, rhinoconjunctivitis, hay fever in the spring, and asthma with proclivity in the winter. Can present as a dry cough only. You need to know that tangentially for family medicine for 2CK, that 1/3 of asthma patients present with only dry cough. It's called cough variant asthma. Okay, so eczema in the summer, hay fever in the spring, and just a dry cough in the winter with no medications, and that's actually asthma. Okay, so the point is, it's fucking asthma. Now let's look acute asthma attack. Let's look at the arrows here. So let's start with CO2. Now, instantaneously, this is where a good percentage of you guys watching this are going to get this wrong, okay? It's a down arrow for CO2, not an up arrow. Now, some of you instantaneously confused because in acute asthma attack, you need to know that you're hyperventilating and that even if the lungs are fucked up, the surface area that we have in the lungs still normal. Okay, this isn't emphysema with COPD where we have actual loss of alveolar surface area and decreased capillary surface area for gas exchange. In asthma, even though we have bronchiolar constriction, we have secretions within the alveolar spaces, we still have intact surface area for gas exchange. CO2 diffuses quickly, O2 diffuses slowly. So your lungs can be fucked up in asthma, but because you're hyperventilating, your CO2 diffuses quickly, so your CO2 can still get out. Your CO2 is low. O2 can't get in because O2 diffuses slowly, okay? That's what you need to know. So overwhelming majority of conditions for USMLE, insofar as you're hyperventilating, doesn't matter if your lungs are fucked up, your CO2 is going to be low. It's emphysema, it's COPD exacerbation, that's more for 2CK, where because you actually have loss of alveolar surface area, capillary surface area for gas exchange, you can be hyperventilating in a COPD exacerbation and your CO2 is still going to be super fucking high. That's the one exception, okay? But for you guys watching this, you need to know an acute asthma attack, it's a decreased CO2 acutely, okay? When the patient goes on to get tired, if they tell you, an hour later, even with medications, with nebulized albuterol, with oxygen, with IV methylprednisolone for steroids, they tell you his oxygen is still low, but his CO2 has now gone back up, that tells you he's tired and you would intubate, okay? So that's the only time CO2 can go up is when you progress from a type 1 respiratory failure where CO2 and O2 are both low to now you're tired, you begin hypoventilation where your CO2 is high and your O2 is low, okay? But for acute asthma attack, it's a decreased CO2. So let's move on to bicarbonate now. It's no change bicarbonate, okay? This is the other high yield point. It's because the kidneys are not going to have time to compensate. It takes the kidneys at least 12 to 24 hours to begin to move your bicarbonate. So when you're first learning this stuff, especially if you have a good chemistry background, it can paradoxically cause difficulty learning this because you think of CO2 and bicarb as intertwined with carbonic acid, etc. You need to separate them for USMLE, okay? CO2 is your lungs, bicarb is your kidneys. So you can't change your bicarb acutely with asthma attack. So bicarb is normal, okay? So we have a down arrow CO2, no change bicarb. If in contrast, let's say we have a metabolic disturbance, e.g. Any of the mud piles, let's say DKA, where you have metabolic acidosis with a decreased bicarb, well, CO2 can change instantaneously where you breathe it off to compensate because all you have to do is change your respiratory rate, increase your ventilation. But so CO2 can change quickly if your primary disturbance is the bicarb, if it's metabolic, but not the other way around. If your primary disturbance is pulmonary, like we have here, your bicarb can't change quickly because it takes time for the kidney to do that. So our correct answer here is going to be down arrow CO2, no change bicarbonate, up arrow pH, okay? So in acute asthma attack, we have an acute respiratory alkalosis, okay? So our short point of consolidation here is in asthma attack, CO2 is low, not high, and our bicarb is going to be no change. You know the deal. To make more content, if you like my stuff, subscribe my channel. Appreciate your time. That's it.